Hello, everybody. Welcome, everybody, to today's webinar. I am Dr. Mohan Bhatt. I'm a consultant old age psychiatry at Northeast London Foundation Trust. I'm also the academic secretary for the Faculty of Old Age Psychiatry at the college. Today, as part of the webinar, we'll be presenting a case-based discussion focused on young onset dementia, and hope to bring the complexities of assessing, managing, and providing services to the young onset dementia patients through the case-based discussion. To help us with that, we've got Dr. Janet Carter, who is an old age psychiatry consultant, a colleague of mine at Northeast London Foundation Trust. Janet is also an associate professor of old age psychiatry at UCL, Division of Psychiatry. She has set up the old age the young onset dementia service at Northeast London Foundation Trust. She will be leading the case-based discussion and will also provide expert opinion at the Q&A session of the webinar. We've got Paul Gallagher, who is the ST7 trainee in old age psychiatry and is currently working at East London Foundation Trust. He's also an honorary clinical lecturer at QMUL. He was my fellow in medical education a few years ago at Delft Medical Education Department. And I'm also proud to say that I'm his educational supervisor during his higher training. We got Joanna Hugh, who is a ST4 trainee, again in our higher trainee rotation. And she is currently placed in East London Foundation Trust. So both Joanna and Paul will be taking us through the case-based discussion, which will form the basis of the discussion at the end of the webinar. So before I pass on to Janet, some housekeeping rules for you all. I can see that we've got about 500 odd participants logging on at the moment. So please use the Q&A box to add your questions for our speakers. You will see that on your screen. And I would also like the participants to like the questions posted in the Q&A section so that we can then prioritize that during the Q&A session later on. You can also use the chat box for comments and interacting with other attendees. You can see that in the screen as well. After the webinar, you will be sent details of how to watch the recording of today's event later on. Certificates of attendance will be emailed to you next week through the conference department. And finally, please fill in our feedback survey. We really want to hear about your experience today in the webinar, and look out for the link in the chat box. Now, before I hand over to Janet, Paul, and Joe, one final thing. We would like to know how the composition of the audience that we have today. So hence we have a small poll. Please indicate and tick the appropriate category that represents you. So we got, we'll leave a few seconds for that. And okay, hope you have ticked the appropriate categories. Now I shall be handing over to Janet, who will be taking us through the case-based discussion. I'll see you in the Q&A section. Thank you.
Hello, everybody, and a big welcome to the webinar today. And thanks, Mohan, for the introductions, and a special word of thanks to Catherine and the team at the Royal College for hosting the webinar for us today. So we're really delighted that so many people have been able to join us. We believe that actually over 1,000 people actually signed up to join us in the webinar. So That's a staggering degree of interest in the topic. So we're really grateful to you all. We can see that from the poll there's quite a large range of expertise. So the webinar is primarily aimed at trainees. So we hope that we can provide some key learning for the trainees. But for those of you who have a lot more experience in the field, we hope that also this may provide some consolidation of your learning. So I'm delighted to say that the talk today was written and researched by Paul and Joanne, who are presenting. And it really arose out of their interest in the topic, but also from their experience that they'd had relatively limited exposure to young onset dementia during their training. And they wanted to learn a bit more about it by reading some key papers. And as a result of that, they were able to put together the case that we're going to hear about shortly. So it's a fictionalized case, so we're not disclosing any personally identifiable data. And rather than focusing on sort of precise areas of diagnosis and support in a very detailed way because of time limits, we're going to try to highlight complexity, as Mohan said, and really the range of issues that can arise during the assessment of a young person living with dementia. So we hope we can highlight some elements of best practice in diagnosis for you and also raise awareness of some common psychosocial issues. So I'm delighted to hand over to Paul, who's going to start leading the case-based discussion today. Thank you.
Thank you, Janet. Good afternoon, everybody. I will share my screen in one moment. So, we are going to be looking at young onset dementia, and specifically what we're looking to do is to provide an example and think about some of the examples of the typical presentations that may be encountered within young onset dementias. We'll be looking at, or hopefully picking up, some of the key red flags in the history that will help you to differentiate between a young onset dementia and some of the other conditions that one might encounter within psychiatric settings, but also wider clinical settings. We'll look briefly at some of the investigations and the cognitive testing that would be recommended and what can be useful and what can be has been shown to be helpful and discriminating within these diagnoses, and think a little about the genetic testing that's available and where that role may play a role. Joanne will be looking also at some of the wider social context, but we're also thinking about the barriers in some of the current service models and what constitutes good practice in terms of the assessment. I think the first bit is to describe that young onset dementia sort of is an arbitrary term, picking up any dementia that is someone under the age of 65. And although the majority of dementias do occur in older adults, people over the age of 65, 1 in 20 diagnoses of dementia is still made in this younger population. And it has some quite significant diverse presentations, and these differ a little from the older onsets. But obviously, these are people at a very different stage in their life. Obviously, before the other key arbitrary transition of retirement, they may be more involved in childcare or professional activities, or a whole host of other responsibilities. They may even be caregivers for parents with young onset dementia, as we know that there is a genetic preponderance within these conditions. And although we might think that frontotemporal dementia, sort of the behavioural variant, is the prototypical sort of the poster child for younger onset dementia, Alzheimer's dementias are also, well, they are amongst the commonest dementias within this group, but the atypical presentations, sort of the posterior cortical atrophy or the unusual presentations, are a little bit more common here due to the nature of how the illnesses progress. To draw to give some examples, we're going to be thinking about Mr. MG. This is a gentleman who was 62 years old when he first presented to the older adult services, or sort of referred to the older adult services. And he was an actuary, sort of working in financial consulting. and he'd identified over 2 years that there was this progressive deterioration in his ability to remember things, and sort of using technical terms in a slightly imprecise manner, which was unusual for him. And one of the things that he'd had to do was make very extensive notes and very detailed notes about the matters that he was consulting on. And this had had the impact in terms of he'd recently been made redundant, and since that time he'd become more anxious because he was the main person earning within the family, and there's sort of an identification that whether or not these notes were being made as a way to combat that anxiety as a result of the sort of the memory problems. He lived with his wife at the time, and 2 young children, 15 and 17, and very independent, high functioning in terms of managing his ADLs and still managing to work at the point at which he was referred to the service. I suppose the rhetorical question of how would we proceed with the assessment at this point is, the assessment is essentially the same as how one would assess any dementia or any individual who's come in, and includes the sort of the psychiatric history, but important points are also the family history and collateral history, the mental state, and particularly a neurological examination. And we'll cover a little bit about the cognitive screening, the imaging, and other biological investigations that would be needed. So if we're thinking about him, Mr. MG in specific, these memory difficulties had been observed before the redundancy, so they'd been insidious in onset, and he'd noticed, that he had to had difficulties recalling the technical language. He had to make more and more extensive notes. He was relying upon other people having records of things in order for him to have an accurate recollection of meetings and discussions. And as I said, there was an increase in the anxiety level, but aside from that, there were no mood symptoms that he reported, no problems with sleep, no problems with energy, no problems with appetite, no changes in appetite, no past history of anything like a depression or anxiety previously. All of this had arisen for the first time in his 60s. And there were no psychotic features. There wasn't anything that sort of warned us that this might be a depression or sort of something else going on. Going back, and in this case, the family history was through 3 generations. There was a family history of his, particularly strongly on his mother's side, of a maternal grandmother with Alzheimer's dementia. He couldn't recall at what age that had been picked up. His mother had sort of been diagnosed with Alzheimer's dementia at the age of 63, which would represent a young onset. There was a missing part of the family history, and this was in terms of the maternal aunt who died in her mid-50s. But very notably, he had a first-degree relative, his brother, diagnosed with frontotemporal dementia very early at the age of 43. And there hadn't been any genetic testing. This was a clinical diagnosis at the time. He wasn't certain if there'd been any imaging or anything that had sort of determined this diagnosis. It had been made on the basis of cognitive performance and collateral history. And his brother, quite unfortunately, had had a very rapid progression and passed 5 years after the diagnosis of dementia. The collateral history that was obtained from his wife, there was no observed behaviour or personality changes. He sort of remained this open, calm and laid back individual that he had been describing himself as pre-morbidly. And there were no concerns about these activities of daily living, although they had observed these jerky movements occasionally, sometimes when he was asleep, sometimes through the day, sometimes at night, but he wasn't reporting this was interrupting his sleep. He wasn't waking his wife overnight, but they'd observed this was an unusual pattern because this was new. And so if we proceed with the cognitive examination, the Addenbrooke's cognitive examination didn't come within the clinical range in this case. And you may argue, given this person's high functioning, what a score of 89 would represent. But the most pertinent things to take from this is that the memory domain was the most affected, followed by the fluency. And in terms of his neurological examination, Apart from the myoclonic jerks, nothing was observed. The examination was essentially unremarkable, and the mental state didn't support the diagnosis of anything like a depressive illness or anything along those lines. At this point in the sort of the progression, a diagnosis of amnestic mild cognitive impairment was recorded, and there were further investigations going on at this point, but we'll come to those in a bit more detail in Joanne's part. But to think back through what would be, what would be important and pertinent things to pick up during the process of the assessment, things that we know are indicators of specifically young onset dementias identified within the collateral history, where there's a behavior change, and particularly changes in sympathy or empathy and the capacity for the individual to interact with others can be very indicative, particularly of the behavioral variants of frontotemporal dementia. The compulsive behaviors, again, something that would be picked up, and patterns and changes in the patterns of behavior. There might also be observed changes in appetite preference or swallowing problems. And you think about the oral fixation that would be observed in the frontotemporal dementias. These can be very indicative of sort of a progression of a dementia. But another point is about the occupational history, and particularly the level of daily function. And if you thought about what the score on the Addenbrooke's would represent, you're considering this as somebody who's very highly functioning beforehand, beginning to show sort of a detriment in their level of function that preceded the anxiety and sort of the concerns about that. Thinking about changes in sleep pattern, and another point is particularly changes in ability to read and ability to write. All of these can be indicative that there's a progressive process rather than a depressive illness or something else that's going on here. And as I said, the points within the family history here, he had a very strong family history, particularly the first degree relatives, but going back into 3 generations, there is very high levels of genetic heritability, particularly some of the single mutations that you can encounter that are linked with the younger onset dementias, and being mindful of the missing bits of the family history where people may have predeceased before they started to exhibit symptoms. In terms of the examinations that you can complete, actually the neurological examination is one of the key parts of the assessment here, and looking particularly for any kind of cerebellar signs or fasciculations, any Parkinsonisms or abnormal movements. These may be in the context of an Alzheimer's dementia or sort of thinking along a Lewy body dementia. Any sort of change from normal is pertinent if captured here. And in terms of the cognitive assessment, the Addenbrooke's is a very good way of screening. But if you think about the domains that aren't necessarily captured there, assessments of praxis and complex motor functioning, but also thinking about frontal release signs, and you'll be capturing fluency, but sort of the cognitive flexibility. And it's worth thinking about use of a standardized cognitive tool, sort of particularly the frontal assessment battery, where somebody is presenting at sort of a younger age. One of the things to think about is obviously at the point at which he was assessed initially, we concluded a diagnosis of amnestic MCI. We know that this gentleman has young onset dementia because this is the case series about that. So why was there a delay in the diagnosis in this individual? And we do know there is a delay to the diagnosis greater than that of dementia in older adults. And we know that things that link with that or associated with that are the younger the person is, if there is a personal history of depression, a dementia type other than Alzheimer's or frontotemporal dementia is also linked to a delay in the diagnosis being concluded. And we know that the more services that a person sees, the later that diagnosis is likely to be made. And on average, when looking at sort of doing a retrospective analysis of case notes, people have seen 3 different clinicians, that may be a psychiatrist, maybe a neurologist, before the diagnosis of a young onset dementia is complete, is sort of concluded. Those with another psychiatric disorder, if there's a sort of a diagnosis is made of another psychiatric disorder early on, that can lead to a delay, sometimes many, many years, 3, 4 or more. But the interesting point to take away, the level of cognitive impairment is not specifically associated with the length of delay. And thinking what factors might be associated with delay, looking back at what the analysis of sort of assessments of individuals with young onset dementia, the assessment of the neurological symptoms, particularly cerebellar signs and Parkinsonisms, is often overlooked during an assessment. Looking at praxis and complex motor tasks, again, is something that may be overlooked during an assessment. A review of the behaviour changes is something that is not often completed, but is worth thinking about, particularly to capture some of the frontotemporal dementias, but it may also capture subtle changes in memory if you're thinking more along the lines of some of the Alzheimer's dementias. And using neuroimaging, the majority of cases do get some form of neuroimaging, but a sort of standardized neuroimaging protocol with MRI is something that is sort of identified as not often being completed and is probably quite a worthwhile investigation. And reviewing what the patient and the carer thinks they need before the assessment is something that may not be entirely prominent in everyone's mind, sort of identifying why that person has come and sought at that point of care. One of the commonest things is about differentiating from mood disorders, particularly depression, and the chronology is the key point here. But there may be some hints on the mental state examination, and particularly where there is a change in the speech pattern, particularly where it becomes disfluent or effortful. That is more of an indication the person is having problems with sort of a neurocognitive problem. And abnormal perceptions or abnormal beliefs are more characteristic of psychiatric problems. There may be some exceptions, but one of the bits it's worth thinking about is where there is a concern about whether it may be comorbid depression, using a validated rating scale to assess that individual and comparing that and having that as a record with the cognitive function that you've observed at that point in time. And so we come back to Mr. MG, who at this point has the diagnosis of an amnestic MCI. I believe Joanne will take over from here.
So Mr. MG remained under the services and he had a repeat assessment after 1 year. Showed a deterioration in his ACE score with the memory subset domain decreasing. And most notably, there's deterioration in ADL. So in the past year, he had applied for 4 different jobs and been kind of made redundant from them. He reported difficulties in organizing himself whilst at work, and seems to have lost his jobs due to difficulties functioning appropriately at work. So to think about now what the next steps are for investigation, I'm going to take you through the different investigations that you might consider doing in people with young onset dementia, and then we will apply this to Mr. MG. So the first thing to think about is genetic testing. So it's important to note that the first person to be assessed must be the one affected, so the one you're assessing. And if we look at the table down below, we can see that if there's history of young onset dementia, so less than 65 years old, there are 2 or more affected first degree relatives, the probability of genetic mutation is 15%. But then if the affected first degree relatives are more than 65 years old, the probability decreases to 1%. This highlights the importance of taking an appropriate family history of 3 generations. And so this can inform us in the genetic testing. Of course, people might still choose to test because obviously it affects their kind of children and other family planning. But this is quite important for us as clinicians to note. The main genes that are involved in Alzheimer's disease are listed here on the right of APP, P701, and P702. Next slide, please. For frontotemporal dementia, about 30% of it is genetic and is inherited in autosomal dominant fashion. The behavioral variant frontotemporal dementia accounts for 60% of cases and is the most highly heritable. So the three genes that can be tested for are listed here in this table. I'm not going to go through all of them. Next slide, please. So we now do another audience poll. So we think about imaging. What imaging is available for you to use in your local area? So tick all that apply. And then Catherine, if you can share the results afterwards, please. Is the poll finished? Oh, most people can see the poll results are in. 95% of you have MRI scanning, 88% have CT scanning, and the rest of them much less, with molecular PET down to 7%. Okay. Next slide, please. So the various scans that you can use are listed in this table here. I'm not going to go through all of them, but MRI head, I guess most of you have access to this, and it's quite useful to look at the structure of the brain to see if there's any regional atrophy, to rule out anything like strokes, previous strokes, or tumors. The other scans are more specialist, so some of you might not have access to them, so I guess it depends on what you have. But they are quite useful for ruling out or differentiating between the different types of dementia, because it's sometimes difficult to differentiate between the types based on just the clinical history. So we might need imaging to help us with this. And also with people with young onset dementia might not have the gross changes that you might see in people with older onset dementia. So for example, for the DET scan, you can use it to look for Lewy body dementia, and then some of the other metabolic scans you can differentiate. For example, the HMPO SPECT, you can differentiate between the Alzheimer's, vascular, and frontotemporal dementia, etc. Next slide, please. The other thing to consider is blood testing. So we divided this into routine and rare blood tests. So the routine ones, I guess you would expect to do in everybody. So it's to detect any comorbidity and if got any reversible cause that might be easily treated. So the things you would do is hematology, full blood count, biochemistry tests, and inflammatory markers. For the rare blood tests, we would advise to do all of them in people with young onset dementia, because it's important to exclude this rare physical causes which might be treated or have different treatment from the dementia. So the things to do are kind of immunological tests like autoantibodies, anti-neuronal antibodies, and for limbic encephalitis. And the things to look out for in the clinical history, if there's any kind of rapid onset or any signs of systemic disease, then it will point you towards doing these tests. And also treponemal serology to look for syphilis. Next slide. The other thing that might be available to some people is a CSF testing. So the two things that you will look for in the CSF. So there are some biomarkers that are available for us to look at now. So there are 3 of them in total, as you can see from this chart. And this can help us differentiate between the different types of dementia. So for example, in Alzheimer's disease, you can see a decreased amyloid beta 1 to 42 and increased tau concentrations. And for CJD, you can look for high concentrations of CSF tau. So apart from looking for the CSF biomarkers, the other things you can look at is to kind of rule out any other diagnosis, for instance, multiple sclerosis or infections or chronic infections. So it's important to kind of rule those out if there's any kind of clinical suspicion that these might be the diagnosis. And then we have this little table at the bottom here. It's just a side note to say that sometimes amyloid PET might be available rather than CSF, and you might use that instead. So if you use amyloid PET, you can differentiate between Alzheimer's and FTD. And then if there's any clinically atypical presentations as well, you might consider using kind of CSF or amyloid PET to try and differentiate between the different types of dementia. Okay, next slide. And the last things to consider is EEG and sleep studies. So EEG, you can look at kind of, for instance, loss of alpha rhythm, and distinguish between Alzheimer's and frontotemporal dementia. If there's any kind of epilepsy that might cause the presentation rather than a dementia, or acute encephalopathies. And then sleep studies, sometimes obstructive sleep apnea can present in a way that might be confounding. You might think it's dementia, but of course, obstructive sleep apnea is treatable. It's different kind of treatment from dementia, so it's important to rule that out. So we can see that there are many, many tests that are available for us to do to help us differentiate between the different types of dementia. I just want to say that this is important in young onset dementia because they are affected much younger, and they probably have jobs and things like children or family that they have to look after. So it's quite important to have an accurate diagnosis in this stage, so that we can treat them appropriately. Okay, next slide. So now we come back to Mr. MG. So he had all these tests. So he went to the genetic clinic. He had pre-testing counseling, and the test came back and it showed that he had a PCNA1 mutation, which, if you remember, is one of the mutations that causes Alzheimer's dementia. It's autosomal dominant mutation. He had an MRI head, which was unremarkable, and there was no other kind of indication to do other scans because we kind of, from the clinical history and from the genetic testing, we concluded that he does have Alzheimer's dementia. The blood screen, he had both the rare and routine bloods, and they all came back as normal. So he was diagnosed with a young onset Alzheimer's disease. If you think back to the family history, his younger brother was diagnosed with frontotemporal dementia at the age of 43. But this was done just clinically. He didn't have any genetic testing. It is highly likely that him and his brother had the same genetic mutation of this PCNA1, and his brother likely had Alzheimer's disease. So this highlights that the presentation can be very heterogeneous, even amongst people of the same family. So it's very important to kind of go through the tests and try and differentiate between the different types of dementia, because his brother would have missed out on the treatments for Alzheimer's disease because he was diagnosed with the frontotemporal dementia. Next slide. And then we have an update on the social history. So Mr. MG is the sole breadwinner of the family. Because he's being fired from his various jobs, the family are having to use savings, and his work is very sporadic. His older child has now started university, and the younger child is in sixth form. And also his wife's father has become unwell with physical health problems. So he's moved in with the family, and now they have to look after him as well. So move on. So if we consider the impact of diagnosis, it's much different in people with young onset dementia, because there's wide variation in the support requirements because of the stage of life at diagnosis. So research has shown that 10% of people with young onset dementia still have children in their homes. They might have a parent themselves with young onset dementia that they would have to look after. About 5% are still employed. And 60% of them require significant support, which is more than 5 hours a day from their family. And this results in a loss of income from the family members as well, and of course the individual. So this highlights the importance of kind of early diagnosis, because if this is done earlier, we are able to do vocational rehabilitation for the people, kind of assist them with occupational functioning, so they're able to retain their jobs for as long as possible, and also put in support for their carers and family members. Next slide. So in the case of Mr. MG, he has these two teenage children. So we have to think about if they would like genetic counseling, if they would like to get tested themselves. So this is obviously has huge implications for them and the family. Vocational support as well is very important for Mr. MG to keep him working for as long as possible. We've kind of lost a little bit of the input because there was a little bit of delay in the diagnosis. The other thing to consider is financial advice for him. He might need to think about wanting to put a lasting power of attorney for his finances, because eventually he will lose the capacity to manage his own finances. So it's good to think about these things as soon as possible. And also with his healthcare decisions, in the case that he might need future care, he might want to think about this and maybe even put advanced directives to see what kind of care he would like in the future. Next slide, please. So Paul and I, we came after researching this topic and thinking about the case a little bit. These are the conclusions that we've come up with ourselves. We found that it's really important to take a detailed family history, which I think perhaps we don't do as well in psychiatry. It's important to take at least 3 generations if possible. And if there's any genetic testing that the other family members have done, it's important to note that as well. Neurological examination, which I think sometimes we skip, and it's important to not just do the normal examination, but also to do with the praxis and frontal lobe functions as well. And access to specialist imaging early in the diagnostic journey, because that can really help us differentiate between the types of dementia, which would help us with the management in the future. So if there's any other things or conclusions that you come up with the case, you can put it in the Q&A or the chat, and then we can come to it at the end of the presentation. So if we move on, now I would like to talk about the services that people with young onset dementia might access. So I have another audience poll here. So what services are available for individuals with young onset dementia in your area? So if somebody presents with young onset dementia, which kind of services do they kind of go to, or what is available? Do we have the results of the poll? I don't know if everyone can see this, but 68% of people, the highest percentage, are in the diagnosed in the generic memory clinic and the psychiatric outpatient services. Only 17% of people in this webinar have access to specialist young onset dementia service. Yeah, so that's not great. So if we move on to the next slide, there's a little video that I would like to show. Oh, no, okay. So in terms of the services currently, 1 in 3 diagnoses are made in the memory clinic, which is less than what the poll suggests. 1 in 4 made in the neurology clinic, and less than 1 in 5 in the specialist young onset dementia service, which is kind of approximately what the poll suggests. 42% reported no follow-up 6 weeks after diagnosis. And 70% of family members reported that they didn't have any carers group or respite care. So ongoing care is managed, 1/5 is managed by the Young Onset Dementia Service, a 1/5 is managed by GP, and a shocking 16% have nobody managing their care post-diagnosis. So the state of the current services for people with young onset dementia is not that great. So if we move on to the next slide, there's the video that we would like to show.
If they're going to talk to you, they should look it up. They should read all about it. If they're going to have to, you know, consult with you. They might know dementia, they might know Alzheimer's, but because they're different, what would you call it, strains or different branches of it, and they're actually lost with that. Well, to me, if somebody's going to treat you or somebody's going to work with you, they should learn about your form of dementia or whatever it is, and then they can work out plans to help you. I mean, mine's not so much memory, mine's visual and perceptions, and I can't work out speed, I can't work out distance. I have problems with puddles. To me, they're holes. So they should start learning, you know, try and get you to overcome them, to work with you with them. A lot of doctors and a lot of nurses and a lot of these, when you say of dementia, they think, oh, he's forgetting things. It's not always that.
There's a lot of guilt around having young onset dementia, and a lot of guilt around the consequences of having young onset dementia, by way of job, by way of mortgage, by way of being thrown on the scrap heap and all the rest of it, and cast adrift. And I think what CFT can do with those people is really go into addressing some of those issues and helping people address those issues themselves.
Well, one was that I had trouble with the phone almost from the start. I wouldn't be able to think quick enough. So there'd be a silence, so people would interrupt me and ask another question, and that would just confuse me even more. So we decided that I wouldn't use the phone anymore, that I'd use email. That was one solution. But another one was to work from home 1 day a week, because I was able to. And that gave me the peace that I needed to be able to, you know, I got through more work at home than I ever did in the office.
Was done by the Angela Project. If we go back to the presentation slides. So the Angela project researches young onset dementia, and they interviewed people with young onset dementia and the carers of the people with young onset dementia to find out what they would like from services, what the problems with the current services are, what their experiences are, and what they would like. And as you can see from the video, people with young onset dementia, they want specific information that applies to themselves, not just kind of generic dementia information. They also want support to stay fit, active, and well, and support with their activity and occupation. The carers of people with young onset dementia, they would like specialist support to care for the person with young onset dementia, and also support to retain their own life beyond just caring for the person with young onset dementia, such as employment. So we can see that there are some kind of gaps in the services that are not well catered to the people with young onset dementia that we need addressing in the current services. So next slide, please. If we think about what the kind of gold standard services should be, the research has shown that in specialist services, like specialist young onset dementia services, the satisfaction and the quality of care is the highest. They are most likely to offer the follow-up appointment within 6 weeks, have ongoing care management appointments and care planning. And I think it's quite useful that they have a streamlined diagnostic pathway, so they have access to all the investigations that we talked about earlier, and they see many kind of cases of people who might have young onset dementia, so they are trained and they know how to diagnose young onset dementia, which allows us to have a quicker diagnosis, because as we see, the delays in diagnosis is a huge problem. And they also would have training, or the clinicians would have experience in providing kind of age-appropriate care. They may have access to kind of like OTs or advisors that might be able to help with kind of financial employment issues and kind of care for the people with young onset dementia. The other point to note is that we shouldn't leave the carer out of the kind of services when we provide the services. So we need to acknowledge the importance of the caregiver, because they find that the caregivers think that they are not being recognized for their input, and they don't really understand what a young onset dementia is, so they're not really being explained to. And we should give them appropriate social and professional support. So that's the end of the presentation. I would like to hand back to Dr. Carter, who will make some concluding remarks before we move on to the Q&A. Thank you.
Well, thanks so much to Paul and Joanne for a really comprehensive overview, trying to incorporate and encompass lots of different complex issues in one case. So well done to both of you, and thank you so much for the presentation. Before we hand back to Mohan, I just wanted to make a few concluding remarks. For those of you in the audience who aren't aware, there's a recent updated college report on young onset dementia from 2018. It arose as a result of a recent working party. The working party was led by Bob Barber, and that's a really comprehensive overview of the college's position on young onset dementia. And the college's view is very much that needs for young people with dementia can be met by specialist services, and that particularly that psychiatrists have a very key role in diagnosing dementia of young onset. And within the report, there's lots of key information about specialist services, about working across specialties, and about training and about CPD in this area. So I would urge you to have a look at that college report. For those of you who are less familiar outside the college with resources, I just draw your attention to some resources through Young Dementia UK and the Young Dementia Network. So Young Dementia UK are the main charity for young onset dementia in the UK. And within that organisation, there is a Young Dementia Network. It's free to join. There are about 3,000 members in that network. And that's composed of people who either live with young onset dementia or care for or work with those with young onset dementia. It's a really fantastic set of resources, and there is resources available, as you can see from my little schematic, resources for GPs, diagnostic algorithms to help GPs identify red flags about who to refer. There are specialist leaflets for memory services themselves, which you can have for patients, patient checklists, patient ID cards, for example. And there's also a wealth of information about care pathways. There is an identified care pathway for young onset dementia, and you can see that on the website, and also accessing resources for research papers. So recent research papers which are of interest in the field are summarised by key academics, and all that information is available as well. So I would urge you to have a look at the website of Young Dementia UK if you're particularly interested in the field, and we'll put a couple of links in the follow-up email for you, for those of you who aren't familiar with either of those resources. So it just leaves me to say thank you again to Paul and Joanne. I'm going to conclude the case discussion at this point and hand back to Mohan, who's going to lead us, I think, in our last 10 minutes or so in any pressing Q&A. So thank you everybody for listening.
Thank you, Paul. Thank you, Joanne, and thank you, Janet, for a very stimulating presentation of a case, and a lot of and why I say stimulating is because I can see the Q&A. There's generated plenty of questions. I do not think we can go and answer all of them, but have shortlisted few commonly liked questions, and it will be. I'll start off with the first question. Maybe Janet, you can tell us. Clubbed quite a few of questions together, mainly around the cutoff age for young onset dementia, and there was also a few questions around the nomenclature, whether it should be young onset, early onset, or working age dementia, and its impact on retirement age. So there's quite a cluster of questions around that. Do you want to start off with that?
I'll have a go. Yeah, I mean, I think that this has been an area of much discussion among experts in the field and academics. I know that there is a large international Delphi study being conducted at the moment through the Netherlands to try to be clear about the terminology that is used, and also which types of dementias should be subsumed under the category of young onset dementia. So the common terminology at the moment is basically young onset dementia. And that's because early onset dementia, I think, as somebody mentioned in the chat very wisely, is often complicated by people believing that it just means early in the course of a diagnosis or early in the course of dementia. So it's a bit misleading. So common terminology, certainly in the UK, is young onset dementia, and referring to the individual as a younger person living with dementia. So they're, I guess, some key points about terminology. In relation to cutoff of age, I mean, clearly the key point to make is that age is completely arbitrary here. The age of cutoff at 65 as a cutoff at the moment is completely irrelevant. Essentially, it's just an artificial cutoff, which was devised many years ago to discriminate between people under 65 and over 65, because that was the age of retirement. So it's really meaningless as a way of thinking about dementias, that what's the difference between somebody who has dementia at 64 and somebody who has the dementia at 67? One's young onset, one isn't. I mean, that's not really sensible. So I think a better way to look at it is to think about the specific needs that an individual has. And I think we would all agree that the needs of somebody at a younger age, say under 70 even, are probably very different to those in their late 80s and older, for example, mid 80s and older, for example. So I think it's better to try to look at the needs that arise from the stage of life that somebody has their diagnosis, rather than getting very, very caught up on the precise age. But hopefully we'll have some further information from the consensus opinions from the Netherlands study. Be interesting to see what the general view is about what our terminology should be, and whether having a cutoff is appropriate, and how one might decide that. Hopefully that's a bit helpful.
Thanks, Janet. The next question, again, I've clubbed a couple of things together, is around the examination. There was a question on bedside tests to detect praxis. If the that could be advised, and also particularly referring to the neurological kind of signs, especially myoclonic jerks in the case that Paul and Joe presented. What is the importance of that in differential diagnosis in particular reference to young onset dementia?
Gosh, well, in terms of praxis, I think the key things that you're trying to identify is whether this is idiomotor or ideational apraxia, but also apraxias in speech, I would guess. And I don't know how other people would do this, but I guess the things that I would usually think about doing would be pantomiming, so asking people to, so for example, if you've got a hammer in your hand, show me how you might hammer a nail, show me how you might brush your teeth, show me how you might comb your hair, for example. So pantomiming particular gestures, seeing whether people use a body part as opposed to an instrument. I guess the other thing would be to ask for meaningful hand gestures. Saying, show me how you wave goodbye, show me how you, I don't know, hitch a lift, or those sort of meaningful hand gestures. And then meaningless hand gestures, where you can just make some strange movements with your hand and see if people are able to copy those gestures or not. And then for speech apraxia, I suppose others may use other approaches, but something simple, by like asking somebody to repeat, I know, baby hippopotamus or something, looking for maybe staccato speech or slurring of speech, for example, would be the key neurological signs that you might be looking for. Hope that's helpful. People may want to add more. The other question was about myoclonus. Yeah. So I guess one of the reasons why I think possibly this was focused on in the case presentation was because presenilin 1 mutations, for example, are often characterized by, among other symptoms, myoclonus. So myoclonus is common, as people know, in Alzheimer's disease, but often in older people later on in their condition. But it is a particular characteristic feature of presenilin 1 mutation. So I guess the idea is that if you're going to do a neurological exam and you're observing during the course of the interview, picking up key neurological signs are helpful in terms of potentially giving clues, just clues really to diagnosis. So I guess that was the point of mentioning myoclonus. It's a characteristic feature in presenilin 1 mutations, which may be helpful for people to know.
And just on that continued question was, do we need a neurologist to establish a diagnosis for young onset dementia? Is a question that's been asked.
I think you might guess from my answers possibly no. I think what we're really looking for is to working across specialties, isn't it? I think this is a complex condition often for many people, and everybody brings specialist expertise to the table. I mean, I think that certainly the Royal College's view would be that improving the expertise of psychiatrists in diagnosing young onset dementia. You are specialists in dementia diagnosis and dementia care. So developing our own expertise to feel confident in making a diagnosis, working with others across specialties. I mean, one of the things that we do in my own team, for example, is that we hold regular neurology case conferences with our local neurologists, and we're able to discuss difficult cases, do some, in a very informal way, short case discussions, look at all the scans together, get an expert neuroradiology opinion, and come to some clear discussion. It's a great way of learning, and it's a great way for bouncing ideas off other experts in the field. It generates a lot of cross-referral, both ways, from them to us, from us to them. So yes, I guess I would say that there's no reason why psychiatrists are not able to diagnose young onset dementia. It may be a question of just improving your confidence a little bit in some of these key areas. Hopefully that's helpful. My view may differ to others, I'm not sure.
Thanks. I think looking at the time, I might have just squeeze in one last question, which is around investigations, especially in any particular antibodies that we would be looking for. And is it, what is the specificity of genetic testing versus CSF biomarkers? And also around that is, how easy is it for psychiatrists to access these tests?
Okay, I'll do the autoantibodies first. I mean, I don't know what other people's practice is, but I do a rare cause blood screen in my clinic for the patients that I see. I run a specialist cognitive disorders clinic for people with young onset dementia, and I would look at connective tissue disease antibodies, a paraneoplastic antibody panel, looking at anti-neuronal antibodies. I mean, they would be the key things that I would do, obviously taking into account the clinical presentation and the likelihood of finding a positive result in those circumstances. So I think Joanne gave a relatively comprehensive overview of other autoantibodies on her slide, and I think those slides are available for everybody if they want to look back afterwards, just to remind themselves of what they might want to do in a rare cause screen. Second part of your question, I've totally forgotten, sorry.
Specificity of genetic and CSF marking.
Not sure what specificity means in the context of genetic testing. So in terms of genetic testing, we're looking usually to do a dementia gene panel. So that goes to your local genomics laboratory, and they would do a dementia gene panel for you, where they would identify all the known mutations of FTD, for example, and Alzheimer's disease, and they'll do a gene panel for you. So they'll either tell you whether the known genetic mutations are present in the individual's blood sample or not. If not, it could be that the patient has an unknown mutation, for example, so you're not able to identify a mutation. So they are obviously highly specific tests for known mutations. So that's the value of doing genetic testing.
And can we ask for, how easy is it for the psychiatrist to ask for this?
I think it varies on where you live. So I'm in the North Thames Genomic Hub, and so we have access to the UCLH and Great Ormond Street testing, and there is usually, you can go online, look for your local genetic genomics hub. There are those hubs now, all recently set up all across the UK. They usually have a standard referral form which you can download. You take your blood sample and you can send the request off. So I'm not sure how easy it is to access in other parts of the country, but I do know from a survey that was done that there is a great variation in how much genetic testing is actually done for young people with dementia, I think, as Joanna alluded to. So if you do have opportunities and you think that there's clinical indications, then yeah, it would be good to try to make links to your local genomics hub and get your forms and send off the blood samples in cases that you think are a high risk.
Thank you, Janet. I think we'll kind of finish with the Q&A session. Thank you, Paul and Joanna, for bringing the young onset dementia to life through the case, and very helpful discussion highlighting some of the important aspects and complexities. And thank you, Janet, for being there patiently answering all the complex questions being posed. I'm sure there are plenty more questions, but we, unfortunately, due to time, we can't kind of go through that. Maybe they could email you if possible, and we might get to clarify some of the questions if they want to choose that way. So with this, I want to bring the webinar to a close. It's already past 5. Thank you all panelists for being part of the webinar. We're seeing good kind of feedback from on the chat. So thank you once again, and thank you for Catherine and Chloe behind the scenes to kind of manage this webinar from the college conference unit. So with that, good evening to you all, and see you soon for the college. I think the college runs these webinars, so we'll see you at the next webinar. So bye for now.